It's Friday, the 24th of May, 2024. This is the Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor of RheumNow.com. This week on the podcast, big buck drugs, opioids and rheumatology, really? And what happens when we don't treat inflammatory arthritis, and why is that? I don't know if you saw this Annals of Internal Medicine article on monoclonal gammopathy of unknown significance and a non-association with autoimmune disease. I thought it was surprising. We have these patients, do we not? I think I must have 5 or 6 RA patients alone and a few others amongst the other autoimmune diseases. And so I always thought there was an association, kind of made some sort of immunologic sense. But in this study, I think it was 75,000, it was a population-based study, 75,000 people in Iceland, and amongst them they found 10,000 who had autoimmune disease, and amongst those there were 599 who had MGUS. Well, overall, their analysis showed no significant association between autoimmune rheumatic disease and monoclonal gammopathy of unknown significance. They did say that if you did have that association, it was probably because you had the MGUS before the diagnosis of autoimmune disease. I don't know if, I think maybe the take home point is that should you be screening for this in your patients? I think now, not routinely so. A study coming out of France from Lille University looked at their cohort of systemic sclerosis patients, 485 patients, and they interestingly looked at the incidence of osteoporosis. I thought this was shocking. 23% had osteoporosis, 18% with fragility fractures. Osteoporosis in this cohort was associated with, independently linked to, increasing age. That would make some sense, a 6% increase. Topoisomerase 1 antibody positivity, I guess that means you're more likely to see this with the diffuse form and systemic form rather than the limited form, and not surprisingly, glucocorticoid. Each of those were independent predictors. I must say, I don't usually think of osteoporosis in my systemic sclerosis patients, but I don't have many over the age of 50. But I don't think you need to wait till age being a factor to consider this. Interesting. It's a karaoke study. I love karaoke. Invite me sometime. Out of Australia, 262 patients with osteoarthritis of the knee, and they went into a double-blind randomized controlled trial of krill oil, 2 grams a day, that's right, versus placebo, 2 grams of placebo a day, and at the end of 24 weeks, no significant benefit. Both groups had a roughly 20-point drop on a 100-point VAS pain scale, and showed no benefit. So one of the things about the study was to get in, you had to have inflammation on MRI with either an effusion or synovitis. Most of those were effusions. I don't think that's where krill oil would be indicated unless you think krill oil is somehow a truly anti-inflammatory supplemental agent, and I don't believe it to be so. So the question here is, did they use enough? Did they study the wrong patients? Or is this true? I think this is true. If you don't think so, repeat the study and do it your way. I like numbers on what we spend or what we prescribe on drugs. And this week came out the 2023 top selling drugs. I listed 11 of them. I'll give you the 11 that were of relevance to you and your practice. But dominating the group here is really the GLP-1 agonists, Mounjaro and Ozempic. Ozempic was number one at $38 billion spent in 2023. But number 11 was Skyrizi, the IL-23 inhibitor. That's interesting, and I think expected to some extent. Number 6 was Stelara, still at almost $9 billion. And I think the big surprise, and think of all the other drugs that you think are doing great, including JAK inhibitors, whatnot, they didn't make the top 11 here. The number 2 drug was Humira. What? Humira at $35.3 billion. Now, I think this must be worldwide sales, although the article said this was U.S. sales. But, prior to Humira going off patent, it was selling like not quite, somewhere in the $21 billion range worldwide. So I guess with the expansion, maybe are they counting here the biosimilars? But, if this is true, then I would have to say that yes, putting biosimilars in the marketplace is going to increase the use and maybe the access to a particular drug or class. Again, none of this data comes with details that I can really be clear about this, but I thought you'd be interested in the numbers. I don't know if you saw this data about psoriasis and how many of those, there's this literature out there that about is psoriasis preclinical psoriatic arthritis? And there's a lot of population-based studies to suggest that. Some have suggested that those who get treated more aggressively with biologics are less likely to develop this. These are flawed in design. But in this particular study, they looked at 384 patients with psoriasis, followed for almost 3 years. 14% developed new onset psoriatic arthritis. But when they assayed these people or look at them further, they said 81% had arthralgia, and they called those subclinical PSAs, like you would call subclinical or pre-RA. And do they develop? And they saw that within 1 year, 9.4% developed PSA. So these are psoriasis patients with arthralgia. Within 1 year, of the 384, 9% developed psoriatic arthritis. But you follow them out to 12 months, it's 23%. I think it was 36% by 3 years. So it's not unlike what we see with RA, is it not? Where if you have arthralgia and ACPA, you're going to have at least a 30% chance of developing. Interesting. So they say basically subclinical with arthralgia, psoriasis has an 11-fold higher risk, almost 12-fold, 11.6, 11.7, higher risk of developing PSA. A Brazilian study looked at 1,000 SPA patients and the influence of B27. This is kind of old hat information. I think you know this, that having B27, 73% did in that cohort, that B27 was associated with being male, an earlier onset and an earlier diagnosis, an increased risk of uveitis, a positive family history. I think they left out, from what I've read, my research, is that B27 increases the risk of axial disease. But B27 negativity was associated with peripheral arthritis, high disease activity, worse quality of life, and worse mobility, and a higher incidence of psoriasis. I think that's kind of interesting, teachable data. Market scan data looked at opioid use in patients with PSA, AS, and RA between 2010 and 2017. Highly prevalent, 30 to 44%, AS 36%, PSA 30%, RA 44% in the year prior to diagnosis, and also then during the first year, similar numbers. I got to believe that this means that they're not in the hands of rheumatologists, that they're out there in the primary care sector, and whoever, and because they have pain, they get opioids and pain medicines. And of course, this is an era, pre-2017, when opioid overuse and deaths were a major problem. I got to think this is curtailed. But obviously, people with inflammatory arthritis don't need opioids as much as they need treatment and diagnosis. And that should be, this is what you should be doing. And I know that you all want to see these patients, but you do nothing to promote that you will see these patients. Meaning, what's your marketing plan? Why are you not writing a letter to your referral base, your primary care sector, saying, I am wildly interested in EGPA. I'm wildly interested in Still's disease. I want to see early RA and newly diagnosed lupus. You send me a text message, I'll see him tomorrow. Without that, these people kind of flounder, and this is why there are delays in diagnosis. And I think we have to assume part of the responsibility of that, and we should be marketing ourselves for what we want to see and what we should be seeing. This is a really interesting study out of the VA database about non-treatment of 18,000 plus VA patients with either RA, SPA, or PSA. 41%. not receiving DMARDs within the 12-month period of study. And I'm sorry, within 12 months of their diagnosis. So you'd think diagnosis leads to referral, referral leads to treatment. Not so. Higher odds of non-treatment if you're African American or Hispanic, 13-14% higher. If you had a Charlson comorbidity score of 2 or more, 15% higher. Opioid use, again, speaking to who's probably managing the patient. And DMARD use was more likely if you were married, if you had erosions, if the provider was a female doctor, and if the diagnosis was made by a rheumatologist. Again, lots of lessons in that good data coming out of the VA. An insurance claim study looked at what happens in newly diagnosed RA patients between 2018 and 2020 who were treated with tofacitinib, almost 2,000, or adalimumab, over 5,000. After propensity matching, significantly higher was dyslipidemia in tofa compared to adalimumab, 25% higher, but no overall differences in MACE or all-cause mortality. This sort of argues against the data from the oral surveillance study, does it not? Where there were higher rates of cancer, MACE, VTE in those who were receiving tofacitinib. Well, this may actually speak to one of the things that you see in real world that you don't see in that study. In that study, it was older people with cardiovascular risk factors. This is all comers. And you're not using, these drugs largely in people who are at greatest risk, over 65, who had a prior MI, who were smokers who had a cardiovascular history. That's why when you look at this in the regular populations, cohort studies, registries, etc., it doesn't pan out. But yet there still is a teaching point coming out of the oral surveillance study. The FDA's adverse event reporting system also looked at this issue of what happens when you look at JAKs compared to, in this case, other JAK inhibitors, compared to other biologic DMARDs. So they looked at 52,000 with tofa, 21,000 with UPA, and 2,000 with baricitinib, and found that JAK inhibitor use compared to other biologic DMARDs had an increased odds ratio or twofold higher risk of VTE events, of a 25% higher risk of cardiovascular disease, ischemic heart disease, 23% higher, edema, 1.22, 22% higher, and tachyarrhythmia is 15% higher. Edema I find surprising. Can't say that's been a feature, but this is the adverse event reporting system. Whatever you report in, right? And this was sort of before, the major release from the FDA about the oral surveillance study, although there were some advisories from the FDA suggesting you should worry about some of these things. So you wonder, is there a reporting bias here? That would be called I think that's called the Hawthorne effect, meaning that when something is brand new and hot, as far as a safety concern, it's more likely to be reported, as opposed to, for instance, a rash with methotrexate, which you've been using since 1984, which, no big deal. Rash occurs in my experience, less than 1% of people with methotrexate. I'm not going to report it. But, if it was an MI or a pulmonary embolism with a JAK inhibitor, people would be more likely to report. That's the Hawthorne effect. We had a number of interesting reports on lupus. Let me see where we got. Okay. Well, let me just give you two. A Greek cohort study, a few. A Greek cohort study of 570 lupus patients. They found that lupus nephritis was the initial presentation at 59. That's 10%. Now, I always teach that lupus never presents as lupus nephritis alone. You're going to meet all the criteria if you're presenting with lupus nephritis. Same thing with cerebritis, right? It'd be really unusual for that to be presenting as the sole organ system where lupus is attacking, in which case, those presentations, you got to look for other diagnoses. But in this case, 10% present with lupus nephritis. And so they found overall lupus nephritis in 22% of their cohort. Predictors of getting lupus nephritis were, number one, male, fourfold higher risk. Diagnosis prior to age 26, 3.7-fold higher risk. High double-stranded DNA, adjusted hazard ratio 2.5. Low complements 2.24. And this all makes some sense. Males, again, if you've got enough of the wrong genetic changes and predispositions to be a male getting lupus, in my opinion, you're going to get bad lupus. And yeah, most of my males that I've ever had did have lupus nephritis, I must say. So I think this was an interesting and very worthwhile report. There are disparities in how we take care of patients, sometimes based on economics, sometimes based on other DEI issues. So in this study, a young adult Medicare cohort of 1,000 SLE patients found that 39% saw a rheumatologist every 6 months. So you wish it was a little bit higher. And 28% had serologic tests, which that was a little bit higher. More importantly, that when they were ranked by economically by the least disadvantaged quintile, they had more clinic visit retention, which is good, but less serologic testing, 20% less, which is bad. Instructive. What about lupus and disease activity? I think there was a very interesting report this week. I think it was ARD that published this. This comes from the International Cooperating Cohort of the SLIC cohort. This is a longitudinal, multinational, multi-center study. Thousands of patients, follow-up of almost 10 years. Overall, half the patients had activity. And what they showed was that in lupus patients who achieved either remission, they had several definitions of remission and also low disease activity state, that if you were either or, you had a significantly lower annual cost of care. That's both direct cost and indirect cost. And I think that's incredibly instructive. Number one, not everybody is controlled. Half your patients theoretically are not controlled worldwide. Maybe you're better than worldwide, but you got to worry about this. And that when they're not controlled, they're going to incur a higher cost. The question is, how are you judging control in your clinic? You know, you don't do a SLIC or a SLEDI or any of the other, newer measures of remission. I think there should be a simple measure in lupus, and for me, the simple measure is no skin, no joint, no organ, and mainly renal I'm worried about. But in some people, it's a hematologic or a neurologic or a serositis or whatever. But no skin, no joint, no organ, and you're in LDA and remission, right? And those three criteria are a conglomerate of both your exam and your labs. Something to aim for. I like this study because it speaks to a window of opportunity. I define a window of opportunity as that period in the care of a patient, whether it's RA, PSA, whatever, where early intervention changes the trajectory of the disease, and therefore in the lifespan of disease, lowers cost, improves outcomes, improves survival, lessens surgery, etc. In this study, which is a Dutch cohort study of 708 PSA patients who were all DMARD naive, all followed for 3 years or more, they found that there were 20% who had very short delays in care, meaning they got seen the quickest, intermediate delays of up to 12 months, I think, in 33%, long delays more than 33%. Delays were more often due to physician delays in referral and being seen. So the primary care delayed referring it to you, you delayed the scheduling of the appointment. These are things that can be worked on. Nonetheless, that if you were in a short delayed group, you had a 2.5-fold higher chance of getting into minimal disease activity or DAPSA remission. DAPSA is just like your disease activity score for psoriatic arthritis, like the CDI. It was invented by Joseph Smolin, who also invented the CDI, SDI, and all of those. Smolin, Ali Taha, co-workers that they work with. So again, this speaks to the fact that you achieve remission much more easily, readily, if you get them sooner. And in your hands, you're going to start therapy early and change that trajectory. What I would like to know is what's the end point of this? What's the 10-year follow-up to this, to those people? And hopefully they'll do that kind of research, but we're going to have to wait a few years for the results. Hope you found this episode of the podcast interesting. You can go to the website and check out these citations and more. Thanks for listening. Be sure to give us a good score on iTunes or wherever you listen to your podcast. Coming up in 2 weeks, it's going to be Room Now's coverage of EULAR. It's going to be fun and exciting. Be there.